So panelists, you are now free to respond.
Sure. Thank you. I just wanted to respond to the comment about engaging stakeholders and teaching our students and residents, language and so forth. And I think engagement is key, just like helping the kids take ownership and become agents for change. When our medical students, or it was our residents, were concerned about obesity and they wanted to fix obesity and they weren't sure where to start. And then they realized they didn't even know, they didn't even have a BMI. So they wanted to, they made a more specific goal of getting the BMI in the chart. Then they had to figure out how to do that. And so then they had to go and talk to the medical assistant, and they didn't just tell the medical assistant what to do. They said, well, what's your job like? How do you want to be involved in this process, or what's busy and hard about it, and how could this fit into the workflow? And they got really the team approach going, and they got a social marketing campaign with a little button that says got BMI, like got milk. So it was just a very creative way to engage the conversation with patients and all the stakeholders, and then they boosted their rates of documentation of BMI from about 4% to over 80%. And then at least it engendered opportunity for discussion with patients about that. But it was an empowerment, stakeholder approach.
Any other comments about the public statements? And if not, if anybody wants to run to the microphone, you get to ask a question. You got a lot of physical activity points, just standing there and shuffling.
Thank you. Hi, I'm Sen Virudachalam. I'm a pediatrician at the Children's Hospital of Philadelphia. My question relates to, again, scalability and sustainability, particularly for Dr. Buchholz and Dr. Burnett. I think it's wonderful, first of all, to hear about the work that you all are doing and see that you've shown success within your intervention that you've designed and implemented already. And I'm curious, as you've started to scale up even on a local level, the challenges that you've faced as far as maintaining fidelity to that intervention that you have so carefully designed, especially when the champions that have really helped to create the success, how do you have a Myrna everywhere, right? So to me, that's a real challenge on the local level. And then as we think about how to scale up such interventions on a state or national level, that fidelity, again, to the intervention seems to become even more of an issue. Perhaps we don't need to maintain as much fidelity to the specifics of the intervention as we think we do, because people need to be able to adjust according to local needs. But I'm curious to hear your thoughts.
I think again, engagement is key, and so there has to be adaptation and tailoring and input and engagement from stakeholders at different localities and different communities, and so different forms may work, and we're starting to be able to apply for grants that have a huge stakeholder component, PCORI and others, so maybe the outcome is not going to be always, or at least not going to be the first time, BMI or A1C. It might be measures of engagement to figure out how does it really work in places, because you can have the best intervention, but if people don't adopt it, then it doesn't do a lot. So I think it does involve shifting our mindset to a bigger frame.
We've certainly had some challenges to be faithful to our intervention, and actually that intervention, as you alluded to, has changed sometimes over time. From making sure that all the different types of staff members at our health center are engaged. There was a point where we almost had a mutiny, and if we didn't have any medical assistants, then it's going to be really, we're kind of up a creek. What we did in responding, our director at the time, Jessica Wallace, our physician assistant, engaged them, and we created a regular lunch meeting where, with the little bit of funding that we had a healthy lunch, and everybody was an equal voice, not just the provider saying, hey, here's what you're going to do, but the medical assistants helping us develop our plans, and we don't have a set specific curriculum, and I suspect that the interventions will vary based on the setting and the patients. I don't think there will be just one curriculum per se that we can magically spread throughout the state, the country, the region, et cetera. But good thoughts, and I think I would agree that engaging everyone, engaging the patients, engaging all the different players, and realizing we're part of a team and it's not just a provider-centric model has really helped.
Just to add to that, I mean, both of these responses indicate a characteristic of how to change primary care. And a guy by the name of Kurt Stange at Case Western has studied this around chronic diseases. And both of these programs reflect a key element of change, and that is staff engagement. Because too often these primary care clinics operate as hierarchies. And what was essential, I think, to both of your presentations was this engaging a wider group of staff and humility, if you will, on the part of physicians in terms of responsiveness to that type of input.
So, Russ Pate gets the last question. I'm going to ask each of the panelists to respond, if appropriate, down the line, and that'll be your last word. So think about the answer and what you want to be kind of your legacy as it relates to this particular panel. Dr. Pate.
Thank you. I would agree with Bill's earlier comment that the problem that we're here talking about today in this session this afternoon may be particularly poorly fit to our existing healthcare system. And it seems to me kids become substantially overweight because of inappropriate diet and physical activity behaviors. And if that's going to change, then those behaviors need to change, and probably profoundly, right, in kids that are already overweight. So the question is, how can you make that happen? And I'm encouraged that we're building out from the clinical environment to the delivery of community-based programs where a hopefully fairly intense intervention can be delivered. But we got to figure out how to pay for that, and as others have asked about how to disseminate it so that it can be delivered widely. So my question is, from your experience, do you have a sense of how much exposure to programs like those that you've been delivering might reliably deliver the behavior change in kids that ultimately will solve their problem and get us where we'd like to be?
It's a nice, easy yes, no question.
Well, let's start down here.
Yeah, I think it'll be appropriate to start at that end. All right. I can appreciate, as you described, the healthcare delivery system as it currently exists is not necessarily a perfect match for the problem which we have at hand. And I think back to Don Berwick at the IHI conference in December, the National Forum, talked about a bridge in Honduras which no longer was over the river that it was supposed to bridge after Hurricane Mitch. And essentially he said that's what we're dealing with the healthcare system and the problems that we have to face. And so we need to figure out how to move that bridge, and I think it will look different than healthcare has in the past. I am biased, I suppose, being in the community health center setting and part of the community health center movement, if you will. But I'm hopeful in that we have a lot of expectations placed on us with more and more people becoming insured through the Affordable Care Act over the next months and years, that we'll be able to take care of a lot more people. But as to the question of how much of the programs which we offer will it take to lead to the behavior change, I don't know. I think I hope to study it further. I have to say that's not been something I can pin down exactly right now.
Part of your question and comment was about, how much does it take? Like, what's the dose? And I think that's different for kids and adults at different, levels, and in particular at different levels of obesity or weight. So for kids who are either normal weight or mildly overweight, once or twice a week, community-based setting, that is effective. We know that we can do that, and it's not that hard to do it, especially if the institution and the organization finds it in their interest and can integrate it. But the heaviest kids, again, need a more intensive intervention. The other piece that I would see about all of this, and now I'm speaking about providers and patients or participants, you know, when they perceive something as being in their interest, of course, then they're going to do it. And that applies to my being a doctor with a patient on any health issue she's seeing me for. So to try to get to the point where, it's fun and it's in somebody's interest, and, there's not an obvious way how to do that, but we got to teach our students, residents to think like that, work in teams. Docs are not the only ones that have the answers. They don't have all the answers. And getting to that point where, people see it as in their interest and it is fun, to do that together. And part of the social marketing is part of that, having things that make it fun and exciting, t-shirts and stuff like that. Then it becomes part of the culture. So that helps, and it makes it fun.
So I'm going to interrupt for 1 second. Those of you on the webinar, this may fade to black in the next 60 seconds. Those of you who are in the audience, please stick around for a few more minutes. Those of you who are on the webinar, please join us again at 8:30 Eastern Time in the morning. And we'll see you back then, and we'll be fading at some point. Now let me go back to the panel for the closeout.
I think that's really a perfect question, because I don't know that we have solid answers to it. I think there are 2 or 3 areas that I think we need to reframe. The first is that we define weight loss in adults as a major struggle. But in fact, adults are losing weight all the time. It's maintenance after weight loss that becomes the issue. And I don't think that's the place where community and clinic come together, because the community level interventions not only prevent obesity, but should help sustain weight loss after it occurs. So that's the first point. The second point is one that I think we've also neglected from the medical side, and that's a focus on weight rather than health at any weight. And I don't think we've invested enough to understand I think we know the benefits of physical activity in people who are overweight. And we know that improves comorbidities without necessarily losing weight, although body composition changes. But I don't think we know a lot about these other behaviors that contribute to obesity, which may have a health impact if we change them, like sugar drink consumption, or sodium intake, or areas like that. The third thing that I think that providers commonly mistake is that their readiness to change doesn't match their readiness for the patient to change doesn't match the patient's readiness to change. And in a busy clinic, that's hard work, because the classic paradigm is providers tell patients what to do and patients go away and do it. That's not going to work and we know that with obesity. And yet the strategy around engagement and understanding where obesity sits in the patient's hierarchy of needs takes some time. And that's where I think the other professionals may be equally important, because providers, physicians, are not trained in behavior change. They need to be, but they're not. And other providers, I think, are going to be far more effective than physicians are, although that doesn't to diminish the role of a physician in calling a weight problem to the attention of a patient, because we know when they do that, patients are more likely to change.
Ladies, Sharon and Pat, y'all can talk about kind of work site as not necessarily relating to this particular question, and then we're going to close it out. Sort of what would be your final points, given everything you've heard and what you brought?
I think in our setting, and I'm going to stick with the worksite wellness because I could go in a lot of areas that overlap with the other panelists in terms of the WIC organization. But I think the one comment I will make is that if we can prevent women from gaining too much weight during pregnancy, a lot of times that prevents them from getting on the cycle of becoming overweight and obese, especially that's what we've seen in terms of our participants. And certainly I think that what's relevant to worksite wellness is that if we can have self-efficacy in terms of our staff and having healthier behaviors, I think that that translates into having a rippling effect to our participants and communities and their families. So I think that's kind of like sums it up for me. I think really we have to think of this worksite wellness in a more expanded version, that it's not just that one employee who's impacted by this change. It has such a bigger scope that I think we don't really always look at. So I think we need to look at it with a larger lens.
And following up on the worksite wellness, I think one of the things that's so disturbing as a researcher is that worksite wellness is so broad, and it just isn't one thing that we can measure. It's so different in every place we go and look at it. All the studies are different. They have different components, and they did it differently. And how often did they do the instant recess? I mean, it's just it makes it a very difficult topic for us all. But I think today we got some of the answers, and it seems like it maybe is fitting a little bit better for me. So just in summary now, I think Ray Baxter said very clearly that we should begin to allow it to be different. I mean, accept the differences, embrace the differences when they're coming from the ground up. And maybe that as researchers, it's a little bit hard for us to handle that. But I think when we're dealing with disparities, he made a very good point that maybe that's essential, that we begin to do that. And when you look at the literature, the big companies who should know how to evaluate whether they're happy with worksite wellness and whether it's meeting their needs and their goals, they've the literature is very positive on that it's a fabulous program, and they're happy they have it, and they think it is doing many of the things that we talk about. But when you put it into a randomized controlled trial, it all falls apart, and you don't get good results. So I think it just has helped me better understand the difficulties that we're all facing as we're trying to move the field forward. And it may require us all to, look at it through a different lens and, accept the good parts and try to, move the field forward given the differences in these fields. And I think, the other panel, there's some of the similarities. You can't pick up their program and move it to another institution necessarily. It may be different in those. And so I think that's the ending that, seems to really resonate for me, that it makes our job more challenging, but interesting.
Well, ladies and gentlemen, thank you for hanging in there. I want to close on a positive note. There's yet another report that says the evidence is mounting that 4 lifestyle changes will protect your heart and decrease mortality. And you know this list: regular exercise, Mediterranean-style diet, healthy weight, not smoking. And I think what we've talked about today in our 2 panels are about how we get to that place where many, many more people are doing that. And so the good news is that there is a promised land for us to be trying to find and get to. And what we need to do is figure out what's the right vehicle to get us there and what's the right map to navigate our way there. And so this evening, navigate your way back to wherever you're going safely, and navigate your way back here in the morning at 8:30 so that we can start the morning part of the panel. Thank you very much for participating.